Magandang gabi po. Thank you very much for that introduction, Dr. Limuel. Again, thank you very much for joining us this evening. Magandang gabi po. Sana lahat nga tayo magandang gabi. No? So thank you very much, of course, for joining us. And hopefully this 1 hour or so will be helpful for you, no, as I prepared for this talk this evening. So again, the talk is about synergies in glycemic therapy and where to find them. So we'll be discussing novel solutions in clinical practice. So I'm Dr. Matawaran. I'm an endocrinologist. And for tonight, so these are my disclosures. And for tonight, we have 3 objectives. So objective number 1 is I will try, to highlight the unmet need for further intensification of therapy in uncontrolled patients treated with oral anti-diabetic drugs. Second, we will also try to demonstrate the limitations of single injectable therapy versus combination therapy at high HbA1c. So again, these are patients uncontrolled on multiple oral anti-diabetic drugs. And lastly, we will discuss the rationale for fixed ratio combination therapies in adults with type 2 diabetes uncontrolled on oral anti-diabetic drugs. So you're quite familiar with this slide. Now, this is basically the natural history of type 2 diabetes. This is quite simplistic when we consider now the data that we know with regards to how patients develop type 2 diabetes. But of course, when we were students back then, we're quite aware of 2 very important pathophysiologic mechanisms why patients develop hyperglycemia due to type 2 diabetes. And primary driver for that, of course, is beta cell dysfunction, as you can see in this slide. And second is what we call insulin resistance. So basically, in the natural history, we see the progressive decline in beta cell function. And this is characterized by reduction, initially by an increased secretion of insulin and eventual reduction in insulin secretion. On the other hand, insulin resistance is a very important characteristic of patients with type 2 diabetes. And this persists from pre-diabetes to onset of hyperglycemia, to diagnosis and eventual chronic hyperglycemia. But we also know now that there are a lot of other hormones as well as conditions that will cause hyperglycemia in type 2 diabetes. And of course, that would include the reduction in incretin function. And this incretin function or incretin hormones, as we all know, are very important hormones that will potentiate insulin secretion. So as you can see in this timeline, you see that patients, even at pre-diabetes, wherein their fasting plasma glucose may still be normal, and yet their post-meal glucose are already elevated, you consistently see a reduction in the ability of the beta cell of the pancreas to secrete insulin. And more so, with the onset of hyperglycemia, and even prior to the diagnosis of diabetes, we see already complications of hyperglycemia. And this, of course, includes both micro and macrovascular complications. To put it more in detail, we now already know that beta cell impairment and loss begins early in the disease course and correlates with high HbA1c. So as you can see with the graph on the left, wherein they looked at and as well as correlated beta cell function, measuring HOMA beta, they looked at the decline in beta cell function in patients at diagnosis. And as you can see, around 50 to 80% decline in beta cell function already at diagnosis. And anytime, you actually go through the progressive nature of the disease, you will see there a rapid drop in beta cell function. So beta cell function continues decline between year 1 and year 2 after diagnosis. So that shows you why it is eventually important that most type 2 diabetics will be needing insulin therapy. So in addition to that, there is also a relationship of the beta cell function and HbA1c, especially in newly diagnosed drug-naive type 2 diabetics. So in this analysis, they looked at different levels of HbA1c at diagnosis from 7 to 8%, 8 to 9%, and more than 9%. As you can see, for those levels of HbA1c, there is a corresponding loss of beta cell function. So as you can see, those who are severely uncontrolled, those with HbA1c of more than 9%, so this correlated to a 62% decline in beta cell function. So that's approximately 2.5 times reduction compared to those patients with HbA1c of between 8 and 9%. So that shows you how important that these patients be controlled early on. Okay, so unfortunately, knowing that in the Discover study, we've learned also that glycemic control in adults with diabetes initiating second-line glucose-lowering therapy is suboptimal. So it takes some time, no? It takes some time for us to initiate, no, and eventually intensify treatment. So that's why we say it is suboptimal. So in the Discover study, we saw that more than half of type 2 diabetics nationwide, worldwide, is intensified at HbA1c of more than 8%. So if you look at the bar graph, so at 23.5, so these are patients with HbA1c of 8 to 8.9 and 26.7% those with 9 HbA1c. So it took about 50% of those patient population with HbA1c of more than 8% for intensification with additional of second glucose lowering drug. Okay, and more than 9% is almost 30%. And you can see here, no, in the map, you see that a proportion of patients with HbA1c of more than 9% per country. You see that 30%, no, of those patients with more than 9% again took some time for intensification, for adding a second line therapy for those patients, especially on metformin alone. So it really we have really patients that have elevated HbA1c before we intensify, even with oral medications. So why is it very important that we intensify early? So because there is data showing to us that early intensification was associated with a larger reduction in HbA1c values across all baseline HbA1c categories. So in this data, among type 2 diabetics in this large US insurance claims database of more than 11,000 type 2 diabetics, who have been using metformin with or without other oral diabetic agents for more than 3 months, they looked at those patients that were intensified within 6 months and beyond 6 months at a particular baseline or index HbA1c. So if you look at the table, the representation here in the graph, so for those patients, for example, with HbA1c between 8 and 9%, okay, at index date, and 9 and 10% at index date, and at more than 10%, they looked at what happened when they initiated therapy within 6 months of that baseline intervention or after 6 months. Okay, so what they've learned is that, of course, when you initiate therapy within 6 months of the index HbA1c, you see a greater reduction in HbA1c. And that reduction was more pronounced, especially for those patients with HbA1c of more than 10%. So I think the bottom line here, if you see a patient with HbA1c of more than 10%, do not wait more than 6 months to intensify treatment. Now, make sure that you lower immediately, knowing the correlation of HbA1c and beta cell decline. So it's important that we do intensify. And not just because of beta cell function as well as HbA1c targets, but we also know now that treatment intensification may decrease the risk of cardiovascular events in patients with type 2 diabetes. So again, in this retrospective observational study wherein they looked at intensification with regards to outcomes of cardiovascular disease. So in those patients, for example, without previous cardiovascular disease, those with previous cardiovascular disease, and the total cohort of patients, they looked at what will be the outcomes with regards to cardiovascular events, occurrence of cardiovascular events for those who were intensified within a year or after 1 year. And they stratified that analysis for those patients with HbA1c of more than 7%, as well as for those patients with more than 7.5%. So just a 0.5% difference in HbA1c. What is very important here is that if you look at the number of events, so if it falls further away from the line of nullity, it means there was a greater risk for having the event. So as you can see here, for those patients that intensified within the year, the hazards ratio, the point estimate was near to the line of nullity. So there is really difference. They're actually less. Now, the risk for having cardiovascular events. Now, for those patients that were intensified within 1 year is considerably less compared to those who were intensified after 1 year. And this is consistent for those patients without previous cardiovascular disease, as well as those patients with previous cardiovascular disease and the total patient population in this retrospective study. So not just benefit on HbA1c, but also benefit with regards to reduction in the risk for cardiovascular events. So it's very important that we do intensify. And when we say intensification, especially if you are on multiple oral anti-diabetic drugs, is you have now to choose the injectables for intensification. So currently, what are the injectables that is available or that are available for intensification? So I've listed here several injectables, so possible first injectables in diabetes care. You have there, of course, your basal insulin. We're quite familiar with this. We have intermediate and ultra long-acting and long-acting basal insulin. So some of us may still be using, of course, your neutral protamine hagedorn or your NPH. No, some of us will still be using our glargine and the U300 glargine. Some would be using the ultra long-acting basal insulin. So other examples of injectable, of course, is your GLP-1 receptor agonist that may be given once daily, twice daily, or even weekly GLP-1 receptor agonist. We also have what we call dual action insulin. So when we say dual action insulin, we have a basal component and a rapid acting component. So be it a premix biphasic human insulin or a biphasic aspart or aspart lyspro or analog. Okay, and of course we also have a dual action co-formulation, meaning a long acting basal insulin and a rapid acting insulin. And of course now currently we also have a fixed ratio combination of insulin with the GLP-1 receptor agonist. So that basal insulin may be combined with an intermediate or a long-acting GLP-1 receptor agonist or a short-acting or prandial GLP-1, which we'll be discussing in detail later. So with this first injectable, we actually may be familiar still with this older ADA guideline. So basically that if you have hyperglycemia, the first choice is to initiate with basal insulin. If you're uncontrolled, you add a prandial insulin, add 1, no, that's what you call your basal plus regimen, or add 2 or 3, that's your basal bolus. If that doesn't work, you can actually use or choose add a GLP-1 receptor agonist and change to a premix insulin. Okay, so basically this was the previous recommendation. No, my beef about this recommendation, it is a traditional one-way intensification strategy whereby you will choose basal insulin ba ako, will premix pa ako, co-formulation, GLP-1 or basal bolus insulin. Okay, so sometimes when you use this traditional intensification algorithm, eventually magde-dead end ka. Okay, there will be no control. Okay, so if we now look at these choices, now what will be the best, okay, initial intensification injectable for my patient? So we'll go and look at the advantages and unfortunately the admit promises of these formulations or injectables. So we'll discuss first an example of a dual action insulin, and this will be your premix insulin. So I have here listed 4 real world evidence showing poor glycemic control with premix insulin. So there are numerous real world evidence studies showing glycemic control remains less than optimal after initiating or switching your patients to premix insulin. You have there the THIN database, the CPRD database in UK, the CODIC database in Japan, and the IDMPS study with showing us the limitations of your premix insulin. So I'll go in detail with the THIN database. So this THIN database looked at the effectiveness of premix insulin to achieve glycemic control in type 2 diabetes. So this is a retrospective cohort from the United Kingdom, and they looked at patients with type 2 diabetes inadequately controlled with 1 or 2 oral anti-diabetic drugs, wherein they were switched to insulin-based therapy if their HbA1c is more than 7.5%, or shifted to premixed insulin as an option for those patients with HbA1c of more than 9%. So they enrolled type 2 diabetics with HbA1c of more than 9% for the premix cohort, inadequate controlled on oral anti-diabetic drugs. Okay? And they eventually analyzed almost 1,000 patients with the primary outcome of measuring incidence of achieving glycemic control over 24 months post-premix insulin initiation. So basically, the key results in the thin database is that the probability of achieving glycemic control of less than 7.5% following premix insulin was low. So only less than 20% were able to achieve an HbA1c of 7.5% for those who were started on HbA1c of more than 9%. Okay, so the highest reduction was seen during 3 to 6 months. That's 18.2% of the population. However, the benefit plateaued after 15 to 24 months. So these are basically the key findings of the thin database using premix insulin. So just to illustrate the cumulative incidence of those patients achieving improved glycemic control after 12 months. So if you look at the slide, basically the graph on the left, so these are patients who were initiated with premix insulin and was able to achieve an HbA1c of 7.5%. So as you can see, this is cumulative incidence of achieving HbA1c. So almost just 20% or about 30% at best were able to achieve an HbA1c of less than 7.5% after 2 years with premix insulin. Okay, what is very important to take note of here is that if you look at the green line here, so those patients with HbA1c of more than 11%, mas konti yung naka-achieve ng HbA1c of 7.5%. Okay, so that the cumulative incidence of glycemic control of less than 7.5 also was shown to plateau at 12 months. So in this case, yung mga naka-achieve ng HbA1c of 7.5% were those patients with HbA1c of 9 to 10, 10 to 11, but those patients with less than 11%, less than 20% pa yung naka-achieve. Okay, and what is important also to take note in this thin database is that at 12 months, as you can see in the line that I represented here, that the benefit of reduction in HbA1c actually plateaued, as you can see here. So there's no, hindi na gumalaw yung reduction na yun. Okay? So that there was somewhat of a threshold with regards to HbA1c reduction for those patients that were started on premix insulin in the thin database. So if you will associate now between baseline characteristic and glycemic control in the thin database, you see here for those patients that were able to achieve an HbA1c of 7.5%, what turned out to be favorable for premix insulin are those patients with baseline HbA1c of between 9 to 10%. But for those patients we have more uncontrolled blood sugar, 10 to 11%, hindi masyadong na-control. So that the thin database showed that participants with baseline HbA1c of 9 to 10% were significantly more likely to achieve glycemic control compared to those patients more than 11% at baseline. Okay, so there is that limitation with premix insulin aside from the plateaued effect after 12 months of therapy, as we saw in the thin database. So how about another dual action insulin? So we have what we call your co-formulations. So co-formulations are also very effective or efficacious with regards to reduction in HbA1c. As you can see in this one trial by Kumar, but the difference was if you compare IDEG-AS, so this is a co-formulation of insulin degludec and aspart compared to insulin glargine alone. They were both efficacious in lowering HbA1c. However, there is an excess of confirmed hypoglycemia for those patients on co-formulation versus those patients on insulin glargine alone. And there was not much difference, so especially in the 7-point profile, okay, in those patients in the co-formulation versus those patients in the basal insulin of glargine alone. So again, there are unmet medical needs with co-formulation, just like what we saw in the premix insulin. How about with using basal insulin alone? So again, this is a retrospective study. This is the UK CPRD. So this is basically a database of patients intensified with either basal insulin or with a GLP-1 receptor agonist. So again, if you look at those patients particularly, they also group those patients who had an HbA1c of between 7 to 8%, 8 to 9%, and those higher at 9%. So if we concentrate yourselves in the line at 9 or higher, okay, so that's in green, you will see that at 12 months, okay, you see at 12 months, no less than 20%, no, we're able to control HbA1c, okay, less than 20% within 1 year and less than 30% within 2 years for those patients that were started on basal insulin alone. Okay, so it may be good or efficient, more efficient, as you can see, for those patients with HbA1c of 7 to 8%, but not as good for those patients with higher HbA1c of more than 9%. And this holds true, again, in the UKC PRD database. This holds true for those patients that were started on GLP-1 receptor agonist alone. As you can see, again, at 12 months, no, around 20% were able to achieve control. But again, less than 30%, no, within 2 years, were able to be controlled with the GLP-1 receptor agonist, especially for those cohort of patients with HbA1c of 9% or higher. So single injectable, okay, or monotherapy may not be enough, especially for those patients with very elevated blood sugar or HbA1c. So this is why it is one of the projects of the ADA, this is the American Diabetes Association, that we as physicians should address therapeutic inertia. So we all know what therapeutic inertia is. So this is an inability of us physicians and even patients to intensify or escalate or even de-escalate treatment. And the ADA identified 3 very easy strategies to overcome therapeutic inertia tomorrow. So it says there, you have to identify and engage patients with likely treatment inertia or therapeutic inertia in your clinic. And who may these patients be? So these are patients with no office visits for the last 4 months and with an HbA1c of more than 9%. So that's why I kept on hammering the 9%. So if your patient did not visit you for the last 4 months and more than 9% ng HbA1c nila, then I think that probably you need to intensify treatment, no, because you are now having therapeutic inertia. Okay, so one option is to schedule what they call a diabetes-only visit. Number 3 initiative is very applicable. So arrange more frequent office visits based on the HbA1c. So 6 to 8 weeks for those with HbA1cs 9% or higher every 2 to 3 months, if less than 7 and 8.9%. But for those patients na controlled less than 7%, pwede 3 to 6 months ang follow-up. Okay, so these are just some suggestions by the ADA with regards to tackling those patients, especially with elevated HbA1c of more than 9%, because baka nagte-therapeutic inertia na tayo. Okay, so if we now go to more specifically to the new recommendation by the ADA, so this is readily downloadable, free of charge. You can download the Standards of Medical Care in Diabetes 2021. So this is from the American Diabetes Association. You have there a very nice algorithm telling us treatment intensification with injectables. Now that algorithm will tell you that patients should be started either on a GLP-1 receptor agonist, maybe started on basal insulin, on prandial insulin as add-on, and it is now recognized in the ADA recommendation that you may also need to consider using fixed ratio combination. So this is a very useful algorithm, very applicable, so that anyone who is uncontrolled with HbA1c above target despite dual or triple therapy, then you need to intensify with injectables. So basically, the recommendation is to choose between a GLP-1 receptor agonist or a basal insulin. But currently, because of the CV outcome trials and again, the outcomes of the CV outcome trials, we now recommend, or the ADA now recommend, considering GLP-1 receptor agonist in most patients prior to insulin as the first injectable of choice. Okay? So if uncontrolled, okay, but there are conditions that insulin may be the first injectable, and these are for patients with elevated, very high HbA1c, 11%. Okay, so better to start on insulin versus a GLP-1 receptor agonist. If your patient is highly catabolic with symptoms or evidence of catabolism, meaning weight loss, polyuria, polydipsia, which suggests insulin deficiency. And if type 1 diabetes is a possibility, then injectable insulin will be a suggested first injectable. If still uncontrolled, for example, with basal insulin, then you may combine. Okay, or if you're uncontrolled with GLP-1 receptor agonist, you may combine. Okay. So what is very important in this algorithm is that there are recommendations now that you can consider as initial injectable a combination of a GLP-1 receptor agonist and a basal insulin. And you consider this combination for those patients with HbA1c of more than 10% or those above 2% from your target. So for example, your target for your patient is 7%, tumating siya 9%, then it may also be reasonable to start your patient on a combination of a fixed ratio combination of a GLP-1 receptor agonist and a basal insulin. Okay, so this is the ADA recommendation. Okay, so with that, we'll try to discuss now the rationale of a fixed ratio combination therapy for those patients uncontrolled on oral anti-diabetic drugs, specifically looking at a basal insulin with an incretin-based therapy. Okay, so why particularly that therapy? Kanina, very simple yung pinakita nating slide on the natural history of diabetes, but we now know that there are a lot of mechanisms causing hyperglycemia in patients with diabetes. So we now know that the brain, appetite, the kidneys, the adipocytes play important roles. So that's why we recognize, for example, the ominous octet as part of the pathophysiologic mechanisms of diabetes. So the value now of combining therapy is very important, knowing that there are a lot of mechanisms, hindi na lang beta cell dysfunction and insulin resistance. So there will now be mechanistic benefit or what we call mechanistic synergy if we combine treatments for type 2 diabetes. So it goes without saying that combining different drug classes may have complementary mechanisms of action. You will be addressing multiple pathophysiologic defects. You have greater potential for beta cell preservation if you do early combination therapy, and you have additive extra glycemic effects now regarding energy balance and organ protection. So we're familiar with CV outcome trials with SGLT2 inhibitors, so especially with GLP-1 receptor agonists likewise. So you can better combine treatment, okay, already in your diabetic patients. Of course, when you do combined treatment, the hyperglycemia correction will be greater. It will be more efficacious with regards to HbA1c reduction. And you'll be targeting both fasting and postprandial hyperglycemia. And of course, we now know that when you do combined treatment, there is greater potential for prevention of cardiovascular complications and nephropathy. You may have lower risk for hypoglycemia, more effective weight control, slower diabetes progression, and of course, improve adherence. And this we get from combining therapy. If you go back to, again, the simple illustration of natural history of diabetes, sabi natin, beta cell dysfunction, incretin effect reduction, insulin resistance are the three more common pathophysiologic mechanisms that we see in type 2 diabetes. So to address beta cell dysfunction, of course, the knee-jerk reaction is to actually give insulin. Okay? And if you want to address incretin function as a good combination therapy for patients with type 2 diabetes, is you give an incretin-based therapy. And we say incretin-based therapy, it could either be you give a DPP-4 inhibitor or a GLP-1 receptor agonist. Okay? So basal insulin with an incretin-based therapy, DPP-4 or a GLP-1 receptor agonist. So these two combinations will actually target many of the pathogenic mechanisms of hyperglycemia in type 2 diabetes. We know there's now a list, sabi natin, ominous octet, causing tissue dysfunction, as well as differences or abnormalities in cellular mechanism, particularly in the mitochondria producing molecular dysfunction. So that when we consider these pathophysiologic mechanisms, as as well as the drugs that can target each of these mechanisms, combining basal insulin, for example, with an incretin-based therapy will actually address most of those pathophysiologic mechanisms, as you can see in this slide. Okay, so that two combination will be a good combination for type 2 diabetes. So now the question is, between incretin-based therapy, ano ba yung ikakabit ko dun sa basal insulin ko kasi mag-intensify na ako? Will a GLP-1 receptor agonist be a good or a better combination versus a DPP-4 inhibitor? So what is good about this incretin-based therapy is that both these two drugs already have CV outcome analysis. Okay, so we know a standalone GLP-1 receptor agonist had better CV outcome analysis. But in this particular study, what they did in this real-world retrospective study, they looked at type 2 diabetics who were initiated with GLP-1 receptor agonists versus those who were initiated with DPP-4 inhibitors. So retrospective analysis na. And they looked at cardiovascular outcomes. So what outcomes were measured? 3-point MACE, meaning non-fatal MI, non-fatal stroke and CV death, myocardial infarction, stroke, death, and heart failure, all-cause mortality and heart failure. So they compared GLP-1 receptor agonists and DPP-4 inhibitors. No? So as you can see in the forest plot, so this is the line of nullity. So all of the point estimate or the hazard risk or the confidence interval are all pointing to the left. So that's GLP-1 receptor agonist. So particularly for 3-point MACE and myocardial infarction, you see that GLP-1 patients that were initiated on GLP-1 receptor agonist showed or exhibited a better cardiovascular outcome over a median of 18 months, no, compared to those patients, similar patients that were started on the DPP-4. Okay, so that is either an intention to treat analysis or actual treated patients. So you see that benefit cardiovascular-wise with the GLP-1 receptor agonist compared to DPP-4 inhibitor. And the benefit was consistent. Now, again, this is the line of nullity, all to the left, no, favoring GLP-1 receptor agonist. They did a subgroup analysis. So it was consistent. If you look at the hazards ratio again on the right, it was consistent regardless of gender, although the benefit was seen more among women. With regards to age, the benefit with regards to CV outcome was more seen in those patients more than 65 years old, as well as those patients with longer duration of diabetes. The benefit was seen regardless if they had baseline cardiovascular disease or not. Okay, so again, very consistent that with GLP-1 receptor agonists, when you measure cardiovascular outcomes, it was favorable compared to those patients that were on DPP-4 inhibitors. And if you look at simply on HbA1c reduction, this is a very nice study looking at the benefit particularly of combining the GLP-1 receptor agonist versus combining basal insulin with a DPP-4 inhibitor. So as you can see here, represented in violet is the glucose excursion of those patients given insulin, glargine, and metformin alone, while those in light green are those patients on insulin, glargine, metformin, and sitagliptin, which is a DPP-4 inhibitor. And of course, the darker line is those patients on insulin, glargine, metformin, and exenatide, which is a GLP-1 receptor agonist. So if you look at the glucose profile, flatter doon sa naka-GLP-1 receptor agonist compared to those patients on DPP-4 inhibitor combined with basal insulin. So that shows you a significant lower postprandial glucose reduction, okay, with GLP-1 receptor agonist versus DPP-4 inhibitor when given in combination with glargine, okay, or your basal insulin. So they also did, so there is a very nice commentary on the benefits of combining basal insulin with GLP-1 receptor agonist. So it says here that glucose control is not just a bystander in GLP-1 receptor agonist mediated protection. Okay, so when they grouped and analyzed the benefit of the different GLP-1 receptor agonist CV outcome trial and looking at the benefit of HbA1c reduction in combination, we saw that for those CV outcome trials of basal insulin with GLP-1 receptor agonist, they saw, if you see the pattern of the graph, it goes down. It was consistent, at least for MACE and stroke, the reduction of the combination therapy with regards to the two outcomes, MACE and stroke. Okay, and there are additional benefits of basal insulin with GLP-1 receptor agonists when they look at the trends of improvements with the lipid profile. Triglyceride, LDL, total cholesterol, and HDL. They analyzed this after adjusting for anti-lipid therapy, weight change, and baseline lipid levels. So when they did compare those patients on insulin glargine plus lixisenatide, which is the combination, fixed ratio combination versus glargine alone, you will see that the parameters, at least for the lipid profile, were all better for those patients on the combination versus those patients in insulin glargine alone. They also did a subgroup analysis for that benefit for those patients with elevated or with low 2-hour postprandial glucose of less than 10 or less than 180. And consistently, you have lower lipid parameters, no, for those patients on insulin glargine, lixisenatide versus glargine alone. So not just blood sugar ang nag-benefit. Lipid profile was also beneficial for those patients with 2-hour postprandial glucose of less than 180, as well as for those patients with elevated postprandial glucose of 180 and above. Okay? If you compare the two, mas mababa pa rin dun sa naka-fixed ratio combination. Okay. In addition, they also did the same analysis for those patients with fasting plasma glucose of less than 110. So again, you have a better lipid profile for those patients on the fixed ratio combination versus insulin glargine alone. And even for those patients with fasting plasma glucose of more than 110, mas maganda pa rin ang fixed ratio combination when we look at lipid profile. Okay, and this is also consistent for those patients who were able to achieve an HbA1c of less than 7%, as well as those patients who were able to achieve an HbA or not able to achieve an HbA1c of 7%, or those with HbA1c of more than 7%. Okay, so that shows you that not just glycemia, CV outcome trial, as well as in lipid profile, the difference of your fixed ratio combination. And in addition, we also have evidence that lixisenatide, which is your GLP-1 receptor agonist, reduces progression of urinary albumin-creatinine ratio in macroalbuminuric patients. That will lower your risk for onset macroalbuminuria. And there are identified mechanisms. So because your GLP-1 receptor agonist can target obesity, dyslipidemia, hyperglycemia, and hypertension. So that would probably be beneficial, okay, causing the better kidney outcomes with GLP-1 receptor agonist, as well as there could be some mechanisms that may address inflammation and renal hypoxia, as you can see in this slide, why there is that benefit. So if we want to combine, for example, basal insulin, now with an incretin with the incretin-based therapy, then probably combining it with the GLP-1 receptor agonist will be best. Okay, how about basal insulin with different forms of GLP-1 receptor agonist? How about using a prandial or a long-acting GLP-1 agonist? So as you can see, the value of your basal insulin, as you can see the box on the left, is that it will decrease hepatic glucose production, thereby reduction of fasting plasma glucose. Now, that's the added benefit or the main therapeutic point for basal insulin. However, okay, there is concomitant body weight gain and hypoglycemia risk, no, if you especially push your doses of basal insulin. Okay, so now if you now decide on combining with an incretin-based therapy, so your choice will be a prandial or a short-acting GLP-1 receptor agonist or a long-acting GLP-1 receptor agonist. So as you can see, aside from fasting blood sugar that you get from basal insulin, you have that additional reduction with regards to postprandial excursion. And with short-acting insulin, you also have that additional reduction in gastric emptying rates. Okay, so you have a feeling of fullness, okay, with your GLP-1 receptor agonist, particularly your short-acting GLP-1 receptor agonist. Okay, so this is to show also efficacy comparing your lixisenatide, which is a short-acting prandial GLP-1 receptor agonist, versus a long-acting GLP-1 receptor agonist, liraglutide. So if you look at those lines in blue, so this is the graph of those patients that was initially started, okay, on liraglutide, okay, at baseline, okay, so at baseline and 28 days after, you see a reduction in mean glucose excursion with liraglutide. However, if you look at the initial glucose profile of those patients started on lixisenatide and then 28 days after, you see that in this 148 adult type 2 diabetics, insufficiently controlled, okay, when given with metformin, when given lixisenatide, you see there a very significant drop, no, in the glucose profile for those patients to given your short-acting prandial lixisenatide compared to those patients on the long-acting liraglutide. Okay, and mechanistically, so why did that translate to that particular finding? We now know that when you do combine your basal insulin with a prandial GLP-1 receptor agonist, we know that it's somewhat, okay, lixisenatide compared to placebo, somewhat reaffirms the first phase insulin release. Okay? So binabalik niyo yung first phase insulin release. So that once you give, for example, sugar, there's hyperglycemia, you see that immediate rise of the first phase insulin response, which is usually blunted in type 2 diabetics. More than that, okay, there's also an effect, no, with regards to glucagon secretion. Kung insulin na nagpapababa ng sugar, glucagon na nagpapataas. So that after a standard meal at baseline, you see there is that rise in glucagon secretion. What happens with lixisenatide, there is that beneficial blunting of the glucagon response. So that's why there is that reduction in glucagon. You somewhat oppose the glucagon effect. So that would, aside from controlling insulin, potentiating insulin action, you likewise blunt the glucagon effect. And the addition, the added effect or the value of your short-acting GLP-1 is that it also slows down your gastric emptying. So this insulin response as well as glucagon response with hyperglycemia compared to placebo show that lixisenatide or your prandial GLP-1 would address, okay, the excursions in blood sugar after food intake. Okay, so that is why combining a GLP-1 receptor agonist and and the basal insulin, particularly in this example, glargine, will be a very important choice, okay, or option in managing your diabetic patients, because basal insulin is the most effective agent in lowering fasting plasma glucose, but it is associated with hypoglycemia and weight gain. But when you do combine your treatment with the short-acting GLP-1 receptor agonist that is effective in lowering postprandial glucose without an intrinsic effect to cause hypoglycemia while promoting weight loss, then this fixed ratio combination, okay, will given or administered once a day, a single injection will provide you improvements with your blood sugar, no, aside from convenience, but also mitigate the side effects of the components of the drugs as monotherapy. Okay? So lastly, so maganda nga ang basal insulin, maganda nga ang prandial GLP-1. So pwede bang one at a time ko bigay? So what will be the value of stepwise versus simultaneous intensification? So there are two trials that the Get-Goal Duo, which basically simulates a stepwise intensification, versus the Lixilan-O trial, which makes use of the fixed ratio combination of glargine and lixisenatide for uncontrolled blood sugar. So the Lixilan-O is basically simultaneous intensification, while the Get-Goal Duo is stepwise, no, intensification. So just to show you the study design so that it will be clear for us. So the Get-Goal Duo, so these are type 2 diabetic patients uncontrolled on oral anti-diabetic drugs. They were started initially on glargine, okay, so basal insulin, and then still uncontrolled, they were started on lixisenatide. Okay, meron pong monotherapy na lixisenatide before. Okay, they were uptitrated 10, 15, and 20 micrograms of lixisenatide versus that of placebo. So this is basically stepwise intensification. Okay, the Lixilan-O trial is basically the same with regards to patient population. These are uncontrolled type 2 diabetics on multiple oral agents, but they're randomized into 3 arms. So they were given lixisenatide alone, insulin glargine alone, and one arm, of course, is the fixed ratio combination. So this was simultaneously initiated, the insulin glargine together with your lixisenatide. So this is stepwise, and this is, of course, simultaneous addition. So if you look at the effects with regards to reduction in HbA1c after 24 weeks, so insulin glargine, this is sequential, and this is simultaneous, and this is stepwise or sequential. You see that there is greater reduction when you use the fixed ratio combination compared to the sequential or stepwise approach of combining your insulin glargine and lixisenatide. So greater reduction in HbA1c, and more patients were able to achieve an HbA1c of less than 7% after 24 weeks with the fixed ratio combination. Other glycemic parameters, fasting plasma glucose change at week 24 was better with the fixed ratio combination, as well as postprandial glucose reduction was better with the fixed ratio combination, and body weight change was actually better still for those patients that were on insulin glargine lixisenatide as fixed ratio versus the stepwise approach. But aside from that, when you look at safety analysis, early treatment with Iglar-Lixi was associated with no increase in hypoglycemia and lower rates of gastrointestinal side effect versus the stepwise approach. So this is from the Get-Go Duo, and this is from the Lixilan-O. So basically, you have less gastrointestinal side effects. So when they did analyze, again, in the Lixilan-O trial, remember there were 3 arms: lixisenatide, insulin glargine, and Iglar-Lixi. When they looked at how fast to achieve glycemic control with insulin glargine lixisenatide compared to insulin glargine alone, you see in this analysis where they looked at 50% of patients achieving HbA1c of less than 7%. As you can see here, this is the x-axis, this is number of days, y-axis is the percentage of patients uncontrolled. Okay, so they started off with more than 7% HbA1c, kaya 100%. So if you look at this analysis of the Lixilan-O trial, you will see that half of those patient population at this particular point, half of those patients were able to achieve an HbA1c of less than 7%. So it took 85 days for those patients on the Iglar-Lixi to get to goal, 50% of them. But it took actually 166 days for those patients on insulin glargine alone to get to goal of less than 7%. So it took them almost double. So it approximately half the time with insulin glargine lixisenatide versus glargine alone to achieve HbA1c of less than 7%. So those evidences or pieces of evidence tells you the benefit, particularly for those with high blood sugar, in using the fixed ratio combination. So basically, in all practicality, how do we now start our patients that are insulin naive? Okay, from multiple oral, paano ba natin siya gagawin? So you can use the insulin Iglar-Lixi. This is peach. Okay, so this is 100 units per 50 in 50 micrograms of lixisenatide. So for insulin naive patient, tandaan nyo lang, you start at 10 units. Just like the recommendation on how you start insulin glargine. Okay, so with that particular dose of 10 units, you basically have 5 micrograms of lixisenatide. Okay, with this particular pen, okay, the peach pen or the yellow pen, you can deliver as much as 40 units, which corresponds to the maximum dose of lixisenatide, which is 20 micrograms. So, pwedeng ang intindihin nyo na lang yung glargine. Okay, so when you start at 10 units, okay, you titrate using your fasting plasma glucose. Again, just how you use your glargine. Okay, fix the fasting first. So, but for doses more than 40 units, okay, you should continue now with another pen, with a 30 to 60 unit pen, which is the olive pen, okay, that can deliver doses up to 60 units, which is the maximal dose of the pen, Okay, so this is a stepwise approach in the intensification as well as initiation and intensification. So for insulin naive patients, start with 10 units of the peach pen, which contains 100 by 50 micrograms of lixisenatide. You up-titrate up to 40 units. That's the maximum dose at least of the peach pen that can be delivered. And dosing should be titrated based on the fasting plasma glucose, in accordance with individual patient needs. So if you now exceed more than 40 units, you can now shift, okay, to the olive pen, and which may be titrated up to 60 dose steps with this pen. Okay, so part of the things that you have to remember is that for total daily doses of more than 60 dose steps per day, Iglar-Lixi must not be used. No? Because that's beyond the recommendation. Okay. So what are other practical advice for your patients? So make an effort to reduce the oral meds when you use a fixed ratio combination, especially taking out your DPP-4 inhibitor. So there's no additional benefit of giving a DPP-4 inhibitor kasi naka-GLP-1 receptor agonist na siya. So you can also back off your secretagogues, your sulfonylurea, because you're now using a basal insulin. This will eventually simplify therapy and reduce pill burden and address economy, di ba? GI side effects, usually nausea may be experienced. So you ask your patient to eat smaller meals, eat only until full, do not overeat, and avoid high-fat food. Okay? So to remember, to make things simple at the beginning, start with the 10 units of the peach pen, titrate using the fasting plasma glucose or fix the fasting first, and simple overall therapy will eventually decrease pill burden, may result in overall cost savings, and if further intensification is required, you continue just the up titration. Okay, with the use of a fixed ratio combination as a single injection, it will reduce the number of injections, but this will be enough to cover the 3 meals. Okay, when you use the fixed ratio combination. So in conclusion, hopefully I was able to achieve our objectives, no? And that despite advances in therapy for type 2 diabetes, many people with type 2 diabetes are not achieving their glycemic goals, and the lack of control may lead to complications. We also know now that for individuals with HbA1c of more than 9%, particularly, the probability of achieving glycemic control with one injectable is low. So that, okay, Iglar-Lixi as a fixed ratio combination is a treatment option as first injectable for type 2 diabetic patients with high HbA1c because of the superior efficacy of the fixed ratio combination versus basal insulin and GLP-1 receptor agonist as given as monotherapy. Giving the fixed ratio combination will address the multiple pathophysiologic defects in type 2 diabetes, thus addressing complementary mechanisms of action. You don't see that much weight gain, and there's low hypoglycemia risk with the fixed ratio combination. And of course, it would simplify therapy. Okay, so with that, thank you very much. Magandang gabi po.
Thank you so very much.